Hello, can anybody hear me? Oh, Marcio, you declined. Did everyone decline to be in the panel? That's okay. You don't have to come in the panel, but I need to know if it's working. You're welcome to stay if you don't want to come in the panel. That's no problem. But would appreciate feedback if you can hear me. Okay, well, okay. Hey. How you doing, Paulo? Can you hear me?
Very, very well, John. Thank you.
Okay, good. Did you want to test the video or does Dr. Almefti want to test it?
Yeah, I can test while we are waiting for him.
Okay,
Can I share my
yeah, go ahead. Are you doing okay?
Okay, thank you.
Oh, did you get everything? Paulo, did you get everything?
Yes, sir.
We're good, okay. And Dr. Al-Mefdi,
Okay.
right? He's coming in,
Hey,
Dr. Al.
John,
Yeah,
hello, John.
yes, hi. Yes. Can I help you, Dr. Al-Mefdi? Oh, there he is.
John,
Okay, yeah, okay, I see he's here. Yeah.
thank you.
Okay, hi, Dr. Al-Mefdi. Welcome.
Your
Hi, John. How are you?
Yeah.
I see you
your
John.
microphone is
disappeared.
mute, Professor.
Yeah,
Thank
Paulo,
you.
your microphone is, oh,
We can't hear you.
you
Oh, you
can't
can't
hear me?
hear me.
Can you hear me, Paulo?
I hear you. Hold on.
Okay,
Thank you, John.
okay, you want to, Dr. Al-Mefdi wants to go through some videos, right?
Can't hear you too.
How about now? You hear?
Yeah,
Yes, sir.
yes.
Let me see if I convert it to. Can you talk?
Yeah, we can hear you fine.
We can hear fine.
Yeah, but how about now? Can you talk?
Yeah, that sounds
Yes,
clear.
sir.
I'm not getting it in my ear. Hold
Oh,
on.
you don't hear us? Yeah, so your audio is not working, right?
Yes.
It has you connected, okay. You do have an audio. Can you hear me, Dr. Osama?
But I hear you, but not through the iPhone.
Oh, okay. Well, does that work okay? Here's Jeremy.
One more time.
Okay, can you hear okay now?
Still the same thing. It's the problem from me here. It's not going to my earpod,
Oh, okay.
but it comes through the mic computer. So
Well,
I have to find out how to change it.
well, you know, one thing we can try is for you to reboot your whole computer. and then it might go to the right setting by itself. Do you understand? Can you hear me, Dr. Almefti? Reboot totally. And then it goes back to your, it may go back to your correct settings. I don't know if he hears me. Do you hear me? Oh, okay. Okay. Camera. Can you hear now?
Now you hear me?
Yes, I can hear you. Can you hear me?
Not through my, hold on. Try again.
Okay, testing, 1, 2, testing, 1, 2, testing. Testing, 1, 2. Can you reboot your system? I don't know why you're not getting messages.
How about now? You hear me?
Yes, I can hear you. Can you hear me?
And I hear you well.
Yes,
We
sir.
got it.
Oh, okay.
We got it. We got
Good.
it. Thank you, John. Can I try my,
Yeah, you want to try your video?
yeah, share the screen? We finally got it. I'm sorry, I'm totally,
Oh, you know, I have trouble with the sound all the time. All the time. I can never figure it out.
but I'm really illiterate, so.
Well, you know, just remember, reboot. Usually that works. It goes back to the settings, the correct settings.
Yeah.
Yeah,
Now, you see my screen?
You know, hold on, you haven't started
No.
sharing. No, you haven't started sharing yet.
I didn't share?
No, you need to click on the screen, share screen button. At the bottom of the screen, it should be share.
Yeah, I know.
Yep.
Here we go.
And once you click that, you'll have options of which screen you want to share. There you go. Okay. Just go where you want to go. You're sharing that screen.
You see it now?
Yes, okay. Now make it, there you go. You got large screen. You know most doctors.
You got me well now?
Yeah,
on?
well, you know that conference we had from Cairo, there's not many doctors that knew that. I was surprised. I was surprised. They didn't know where the button is to maximize it. I was surprised. Yeah, that's good. Nice
Is
and
it playing?
yeah, nice and big. Yep.
A lot of lag or no lag?
Well, no, not too bad. No, it goes, yeah, it just melds to the next scene. Did you have to do something special for that video effect? Oh.
Is it lagging a lot or okay?
No, it seems
So
okay.
it's okay.
Okay. And this
Yes, sir.
is good?
Good.
Okay. That's it. No, I have one more, I think. Look at this beautiful things.
Yeah. Whoever thought we'd see the day, huh?
This is good.
Yes.
Yes, sir.
And the last. You see that little perforator coming out?
Yes, sir.
Okay. That's all I want to show. And this lady running. Okay. I'm done. Thank you, John. I really appreciate starting a little early to be sure.
Well, yeah, that's no problem. It saves me effort later and stopping the conference, which we do. But that's okay. Now, how often do you give webcasts down to Brazil from Brigham, Osama? How often? Just occasionally or just when they invite you?
Now, when the corona came in, we were just about every day.
If you guys are interested in doing a channel, I'd be glad to host it.
Sure. And
You
then
want to-
we got vaccinated, so I think everybody kind of had enough Zoom and
Oh, okay.
kind of was longing to in person. But now I think it's coming back to a balance. The in person has its role and the virtual has its role.
Yeah, it's increasing. It's increasing a lot. But if you,
Now, once a while, I think our ground round is still kind of a mixture, virtual and
I would love to televise that. I don't know, I think there's any legal reason if they televise it to other people. Do they televise it now or is it closed?
I will connect you to Tim Smith. He
Yeah,
is the one who's running all ground round and our conferences.
yeah, I would love to televise that.
So,
That would get a lot.
yeah.
I think that would get a
But
lot.
we done broadcast it to the world. The Zoom part of it is for the Brigham people who did not come to the conference room.
Oh, okay. Well, you can
So
always
it's all
make it private.
internal.
Well, yeah, it would be, you just make it private on the Zoom, that's all. You don't, no one gets the link other than people you give it to.
Let me put you on in touch with Tim Smith.
Okay, just, you want to send me his email or something, or
Yeah,
before I
yeah.
forget? Just put it in the chat.
Or yeah. I don't have it here, but I will.
Okay, I'll remind you. I'll remind you.
Yeah. Send me your email so I could send it to you.
Okay,
Or I just could forward your email to him and
okay.
where's Borba? In the operating room?
No,
Not
no.
here.
Today we had a minor case.
Oh.
I think he's about to enter. He's in campaign. He's in campaign, Professor.
Leandro Borba, is that any relation?
Leandro Borba is now in Salvador, Bahia.
I'm
Hello,
gonna
everybody.
stop sharing, huh?
Leandro, abraço.
Leonardo Borba.
Professor, long time no see. Good to see you again.
How are you?
Good.
So we have now double Borba, handsome,
Oh, yeah.
strong, and then old and bold. What
Yeah.
is he?
Borba just sent me an email that he's not getting the registration.
I had a problem with the link.
Oh, you did?
Yeah, so I entered through a link via email. I got an email, so that's how I got in.
Okay.
I'll send him the link that you send me.
Okay. I sent you a couple different links. Yeah, Lewis now is contacting me.
I have two more names for the academy.
Yeah, Sam.
Yeah, Lewis is on the other line now.
Hello. I saw in the folder the picture of the brainstem. That's the picture that I needed last week.
Which one?
Oh, here's
Well,
Lewis.
the picture on the folder with the seventh nucleus and
yeah. No, I
intrapontine
have to give.
segment. Yeah.
Which picture is this?
It's the one of the fourth ventricle.
Yeah.
He gave a lecture of the facial nerve anatomy last week. Beautiful lecture. Very nice lecture.
Good, thanks.
I
don't
see
have
double
this.
Borba now.
Oh, professor's here.
Do I have a sixth nerve or there is two Borba?
No, professor, you're perfectly fine.
Borba, we want to see you. Okay, we want to hear you.
He's working with the link, Professor. We have, let me try. We're going to send all the links again here.
Is it 7 o'clock there now?
We still have 5 minutes, Professor.
Yeah. No, I mean it's 7 o'clock as the time difference.
Oh,
Yeah,
no,
it's 1 hour ahead.
we got 5 minutes, right? In Miami, it's 5:55. Brazil, 6:55, right?
6:55. Here he is.
Yeah.
Now I hear you.
Okay.
But Dr. Almefti, could you move your camera up a little bit because you're cutting off your chin?
Oh, okay.
There you go, the whole face, yeah.
And
You
put
can
some
see it.
light on it too. That's better.
Yeah, that's good.
Hey, Borba.
Hello, Professor. How are you?
We're good. How are you?
Fine. I was trying to send the link to everyone. Abudi
Yeah.
was right.
Who was who was right?
Abud.
In the
Abu.
morning,
The
In the
link
morning,
was
Abud-
working on the phone, but was
Yeah.
not working on the computer.
Where's Abud now?
no,
I don't
no,
know.
he sent me a message in the morning saying that the link was not working.
Mm.
Yeah, well, I hadn't turned it on yet. I turned it
Yeah,
on.
so I showed Borba, and he
Yeah.
said, "Yeah, but the thing was not."
No, I turned it on today.
Hey,
Hello,
Marcio.
Marcio. ¿Cómo está?
Hello, everyone. Hello, Dr. Barba. Paulo, Dr. Mefti, Leandro, John.
Good day.
Not
Uh-huh.
operating today, Marcio?
No, not today. Just clinics.
Oh, chronic is bad.
No, but for them, it's the money day, Professor.
Yeah, he's the best neurologist in Sao Paulo.
No. I don't think I am.
If he just find an operation for migraine, he got 1,000 people.
Oh, yeah. I'll be millionaire.
And I see Antonio coming in.
Antonio here. Oh, look at.
Hi, sir.
Hello,
How are you?
Antonio.
Hi, Paulo. Hi, Marcio.
Oh, Antonio.
That's the real surgeon. He still have the cap and the mask.
Hi, Borba.
What? Hello. Oh,
They say that carioca doesn't work.
até o link se apareceu, cara. É. É. What time is now? I have 2 minutes here. Do you know? Hello, John.
Yeah, 2 minutes.
We just sent them.
Yeah.
I don't know. A lot of people use the wrong link. Now it's working. Let me see.
Yeah, I more or less turned it on in the afternoon. But so I introduce you to Louis, and you run the show, right? I just introduced you. You're
Yeah.
moderating, right? Everything? Can you hear me, Louis?
There is a Portuguese guy here.
Yeah, what time is it in Portugal?
John, can you put me as a co-host?
Yes. Who?
Oh, it's 11 o'clock.
Who you want to be
11
called?
o'clock.
Yes.
Okay. Anybody else?
Just me.
Okay. Okay, you ready?
Okay, 7 o'clock.
Yeah, you ready?
It
10.
should be can you record? Yeah.
Okay, once I say one, I start recording. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good afternoon. This is Dr. John Bennett broadcasting from the home of Neurosurgical TV, Miami Beach. Today we have another Hospital Mackenzie Neurosurgery Grand Rounds. and Louis Borba, famed neurosurgical, big neurosurgical educator from Brazil, is going to moderate. Welcome, Louis.
Hello, John. Hello, John. Good evening, everyone. Today, a very special day. Our joint meeting is our medical school with the World Federation in Latin American Federation. We have the special guest. One guy is working with us now, is not more guest, is our partner, Professor Paulo Cadre, that's work with us here in Curitiba, show all his expertise in anatomy. When the book's coming, Paulo? Soon.
As soon as I finish the corrections.
Oh, 1 year more. Oh, Dr. Omefti will kill you. It's not finished this month. Thank you, Paulo. Thank you. I know you show us a beautiful, beautiful anatomy and approach to the Brainstem. And our mentor and beast, the great of all time of neurosurgeon, Professor Osama Omefti. Thank you, sir. What time is now in Boston? 6 p.m., no? 1 hour
6
left or
p.m.
2 hours left?
1 hour.
1 hour. You should be
But
in the
we're-
war.
But we're behind, you know, you're ahead.
Okay. Today we see a lot of people talking about surgery of the brainstem and neuronavigation, neuromonitoring, more the technology than the real understand. And there is one thing that never change. There is no problem with technology. Is to understand the anatomy. If you know the anatomy, you'll be your best neuronavigation. If you know the anatomy show the safe way to go to everywhere. And the brainstem is maybe the most important place. You are very pleased to have here Paulo Cadre and Professor Omefti to talk about that after discuss the way that you always do. Let's start with our professor and partner now, Professor Paulo Cadre, that will show some tips in anatomy and surgery anatomy of the brainstem. And after Professor Omefti, you show all his expertise and wisdom about this area.
Okay. Borba,
Please, Paulo,
we made,
go ahead.
thank you so much. We made a little combined presentation. So Professor Omefti will start the presentation, then I
Okay.
will go over and show some videos, and then he'll come back to the conclusions and the grand finale.
Okay, that's,
Okay, good.
if Borba permit.
Yes, you can.
Professor
go ahead, sir.
Borba, thank you very much. And it's beautiful to be in the ground round in your university. So that's a privilege thing. You know, with these days, when everybody hesitant to operate and totally remove lesion from the convexity, and they're all talking about debulking to achieve control with minimally invasive keyhole. We want to emphasize with this that even the brainstem is a micro neurosurgical territory to remove the lesion totally in the quest of a cure and not temporizing and what they call a tumor control or lesion control. And this is not a new idea. This is clearly stated a long time ago. And it says there is no brain, no area in the cerebrum cannot be accessed in a proper manner with removal. I have a bar, I want to get it out my face here, so you forgive me for 1 second. Now, so if I want to translate this eloquent statement, if you want to operate in the brainstem, know where you are going. That means you should know the anatomy. Know how to get there, the approach. That means you need the skull-based approaches. Know what to do there. That means you need to be a micro neurosurgeon. A very popular lesion now in the brainstem is the cavernoma. Look, the expulsion of paper and writing about cavernoma. Everybody had a video on cavernoma, and everybody want to write an article about cavernoma. But the things to know about them, that they all have the same face. That's the pathology. A dilated vascular space lined by endothelium with a variety of side sinusoidal caverns. But clinically, there are many entities, from the small intracerebral to the cavernous sinus extradural, to the brainstem one, to the orbit, and to the spinal cord. Many different entities, they all have the same pathological feature of cavernous cells. If you look on the pathogenesis, they're also very different. Radiation, no question, cause cavernomas. Genetic, no question, there is a syndrome of familiar multiple cavernoma. If you have the thrombosis, next to the thrombosed sinus, there is a development of cavernoma. Angiogenesis. There is no question that there is a cavernomas that they are purely vascular malformation that associated with other vascular malformations like a port or skin sinusoidal tumor. And above all, the cavernomas in the middle fossa does not bleed like the one intraparenchymal, but it does grow like a tumor and proliferate and keep on growing. They do not want to say the word cavernoma. They want to call them cavernous venous malformation. Yeah, there is a cavernous venous malformation. But like meningioma, you know, what is meningioma? Meningioma is an umbrella, a diplomatic name Cushing came up with for a multiple features. And I think cavernoma is the same thing. It's just a diplomatic umbrella name for a multiple different entity and etiology. They all have the same face. They're different in epidemiology, different in demographic, different in the associated gene with every one of them. But they all need a treatment. And the treatment definitely not radiation. This is the decisive lecture came out a long time ago from Stockholm. It said it could not be concluded whether gamma knife radiosurgery affect the natural course of a cavernous malformation. That means it doesn't work. the incidence of radiation-induced complication was approximately 7 times higher than expected. That means had a horrible complication. So forget radiation. Now I hear the voices again saying, oh, with gamma knife, the cavernoma and the cavernous sinus, it will melt away. If you look at those papers for a short follow-up, it didn't melt away. It might have a shrink, and that's not surprise, because this is vascular channels with the radiation, it's sclerosis, and the percentage is still there. Paper came in about the magic drug, the propranolol. It kind of make cavernoma in children disappear. Well, there has been a lot of questions of this early enthusiasm. So the treatment of cavernoma, wherever it is and whatever it is, it's ours, the micro neurosurgeon. And probably the subject of today is the one in the brainstem. And why we have to treat them? Because everybody caught that there is only 1.9 incidence of hemorrhage a year. That's in retrospect. That's if you count the year of the patient from the day they're born to the day they bleed. The real risk, if a cavernoma bled today, what's the chances to bleed again, or what the rate of bleeding again? The prospective bleeding. And this beautiful study done by Dr. Regley and his people, it's almost 12% a year. So forget that number of 2% or 1 to 2% in the cavernoma that never bled. You need to deal with the number of 12% bleeding a year with the one which presented to you one day with the bleeding. And the deficit will accumulate and accumulate. And they become harder and harder to reverse. So they need a treatment. The things to know if you want to treat, that there is a very low mortality from the cavernoma itself if you did not intervene. So you have to get to that bar that you have to treat these people without mortality. And you have a lot of theory now with the good mortality or low mortality. What concerning me, that if you look on all of those big theory, it's not here, the post-op deficit is high. It's too high. Reported anywhere between 25 to 50% post-operative deficit. So here the presentation is to see how you could really minimize the post-operative deficit, and to the contrary, seek improvement, and you should expect it post-operatively. And I think the way to really achieve that is the way to approach them, minimizing any risk of main approach to is how to operate them in the brainstem, and that require the entry in the right place at the right time for everyone. So every cavernoma in the brainstem has optimal approach to it and optimal entry into it. And nobody could know that and teach it better than Dr. Kathy. Please, Paulo, I'm done.
Thank you, Professor. Thank you so much. So let me share my screen. Yeah. So thank you once again for the opportunity to share a little bit of what we saw and learned during these years. And it's always amazing to see Professor Almafty talking. He always inspires us so much and give us the courage to go on, to study more and try to do more or less as the same as he did. So I want to start showing you this model. This model was done by Professor Yashardi. So he did cut some of the histological plates, and then he painted and he put wires to try to understand this very, very complicated anatomy, especially because we don't have really 3D models or 3D anatomy to see. Most of what we study are in Excel or coronal cuts, histological staining. So sometimes it's very hard for us in the live patient to really take this reconstruction and identify the structures that you see in the plates. We tried to do, as Professor Yashardi during this time in Boston, and I can tell you it's really complicated, and even today we didn't get even closer to what he did 50 years ago. But now, if we have to think about the brainstem is intersected, it's located between the spinal cord and the diencephalon. It has an anterior, lateral, and posterior surface. Here we are seeing the anterior surface. The limits, the considered limits of the brainstem are superiorly the optical tract and inferiorly the decussation of the pyramidal tracts. So it's from the very top of the mesencephalon all the way down towards the decussation of the pyramid. And we divide the brainstem in what we call the mesencephalon, the pons, and the medulla. Separating the mesencephalon from the pons, we have a sulcus, the pontine mesencephalic sulcus. Anteriorly, we see here the two components, or the anterior component of the mesencephalon, which are the crura. Between the two crura, there is a fossa, and this fossa we call the interpeduncular fossa. And at the depth of the interpeduncular fossa, you have the posterior perforate substance. And also, it is the apparent origin of the third nerve. Now, the pons anteriorly, the superior limit is the pontomesencephalic, and the inferior is the pontomedullary sulcus. Laterally, it is continuous with the middle cerebellar peduncle, and we use the apparent origin of the fifth cranial nerve as the division. Lateral to it, it's the middle cerebellar peduncle. Medial to it, we have the transverse fibers of the pons that are the majority of the connection fibers of the cerebellum. In the anterior portion of the pons, you can see usually a depression. This is the so-called basilar depression or basilar impression. That's not really impression of the basilar artery, because on each side you have an eminence, and this is the so-called pyramidal eminence of the pons. those fibers that are coming out of the cortex and the encephalon going to the pons, they are divided in what we call the frontal, the corticopontine, the corticospinal, and the corticonuclear fibers. Those fibers that will pass through the pons and will again converge to form two eminences on the anterior surface of the medulla, which is called the pyramid. And the pyramids are separated by the anterior medullary sulcus, and lateral to it you have the so-called pre-olivary sulcus, and then there is the eminence of the inferior olive. And the olive also has a posterior olivary sulcus or retro-olivary sulcus that limits anterior a fossa that we call the lateral fossa of the medulla. Lateral fossa of the medulla, where you have posterior to it in what we call the dorsomedullary lateral medullary sulcus, dorsolateral medullary sulcus, the origin of the lower cranial nerves, and on top of it, we have the origin of the facial nerve and the vestibulocochlear nerve. So in these specimens, we can see laterally the superior limit, the optic tract, and we can see the mesencephalon with the crura, and then you have the lateral mesencephalic sulcus that divides anteriorly projection fibers, the base of the mesencephalon, and posteriorly it's the tegmental. Lateral, in this lateral portion, this triangular shape, it's what we call the lateral trigon, or the lemniscal trigon. And you can see that here are the ascending fibers of the lateral lemniscus, the trigeminal lemniscus, and the medial lemniscus. On top of the lateral mesencephalic sulcus, we have the medial geniculate body, and just superior, lateral, and a little bit anterior, you have the lateral geniculate body. Posterior to it, you have the pulvinar and the quadrigeminal space, where you can find the pineal gland. Now notice here the trigeminal, so everything anterior and medial to it, it's pons, while lateral to it, it's the beginning of the horizontal fissure of the cerebellum. It's the fibers of the middle cerebellar peduncle. Here the flocculus, which is the superior boundary of this fossa, just superior and lateral to the olive, where you have the lateral fossa. As we saw, here is the origin where we can see the 7 and 8 cranial nerve complex. So I'm going to put some of Professor Almefte's case that we studied together, and I try to illustrate where or what are the important anatomy in each one of these cases. So here we have a lesion located, a cavernoma, located at the pons. I know that that is the pons because you can see here the middle cerebellar peduncle. It is in the base of the pons, which means that this, in the base of the pons, you have the descending fibers, which might stop in the pons, like the corticopontine and the corticonuclear, but some of these fibers, they will pass through the pons and go all the way towards the medulla. So here is our lesion, almost at the transition of the pons itself towards the middle cerebellar peduncle. Here is the origin of the 5th cranial nerve, and you can see that this fiber is this lesion is related also with the descending fibers. So here it's what we call the base of the pons, while this is the tegmentum of the pons. What is the limit? The limit is the medial lemniscus, the ascending fibers of the medial lemniscus that we're going to see. So here is the location of this lesion if we could put it over the surface. So it is on the transverse fibers of the pons, located more or less between the 5th and the origin of the 7th and the 8th cranial nerve. Here, medially, we have at the ponto medullary sulcus, just lateral to the inferior sacral foramen, the origin of the 6th cranial nerve. Now, Professor Almefti always says that we should be like a thief. We should go remove the interest, remove the treasure, the lesion, and leave all the other tissues as you never passed by them. For that, we have to understand what are those structures that we will have to pass through. Of course, most of the case, you're gonna find where this lesion come to the surface. But in some case, the lesion will not show up on the surface. And then you have to know where to pass through the parenchyma and let to the less damage, and with that less deficits. So if I see here, middle cerebellar peduncle, those fibers cross towards the pontine nuclei, and they do what we call the transverse fibers of the pons. Transverse fibers of the pons, they can be divided in superficial, this one that we are seeing. If I go a little deeper, then I start to see that these fibers, they intersect, they pass through the longitudinal fibers, the descending fibers. Now, some of these descending fibers, as we're going to see, they will continue towards the medulla. So those are the corticospinal. While some will stop in the pons. If we follow these fibers from the most superior aspect, where we have the corona radiata, the capsula interna, and then you have the peduncle, we know that the most medial ones, they are the cortical frontopontine fibers, and the most posterior ones, they are the parieto-occipito-pontine fibers. The corticonuclear fibers that go towards the nerve, the nuclei of the cranial nerves, they are deeper. They will go, and I will show you later, posterior to that. Now then, most of these transverse fibers of the pons, they will do a relay within the nuclear of the pons, the nucleus of the pons, which are also between all these fibers, more superficial. Now, if you go deeper in the dissection, you're going to see that there are a component of fibers that we call the deep stratum, that they are posterior to all projection fibers. And those are what we will call the trapezoid body of the pons. So in this specimen here, you can see the most superficial ones, that they are the corticonuclear fibers. Here you can see the crossing fibers. You can see the fibers that will pass and stop by the pons. Now, deeper to those, you have the fibers of the corticospinal tract. And then there is a space lateral to the corticospinal tract between the 5 and the 7, where you just have transverse fibers of the pons. The inner limit is the ascending fibers of the medial lemniscus after they cross in the tegmentum of the medulla. So this is your inner limit. And those fibers of the trapezoid body usually related to the vestibulum and to the hearing process. So once again, this is the posterior limit of the tegmentum. You can see the medial lemniscus. You can see the very superficial layer of transverse fibers, the intermediate layer that pass through, crossing the descending fibers, and then this deep space that we call the trapezoid body, posterior to the descending fibers of the pons. Now, of course, you do have to find your short, most directly access. For that lesion, we do have to master our skull base approach. Cavernoma is probably the best example where you can mix, or where you have to know not only the intrinsic anatomy of the brainstem, but also how to get there applying the skull base approach. And for that, you do have to master and understand the petrous bone, of course. So in this case, we did what we call the anterior petrosal approach. You do a preauricular, you cut the zygoma so you get enough space to rotate the temporal muscle, to do a very basal craniotomy, so you don't have to retract your temporal lobe. Then you're gonna find your landmarks of the petrous apex, and I'm gonna show you in the video later. But then by removing the petrous apex, you're gonna get your access towards the anterior portion of the pons, or anterior surface of the pons. And this is not new. This actually, Professor Almerti popularized that by removing the zygoma in different ways to gain access to this very basal approach, but this is not a new idea. So even Fraser, and even before Fraser, Andrews, they were already advocate to remove the zygoma so you could get very basal.
Follow your audio, audio. Hello, Paulo? Can you hear me?
Paulo, não estamos te ouvindo.
No audio. That's the thing, he can't hear us. Tell him that. I'll text him. Does anybody have communication with Paulo? Okay, I have his WhatsApp. I just text him.
Wow.
Paulo, can you hear me?
I can hear you. Can you hear me?
Now we can. Now we can. Continue.
Oh, sorry. Should I start all over again?
No,
No.
stop. Maybe no. Do what you want. Maybe about 20 seconds from 20 seconds ago.
Ah, okay.
The video.
The video audio.
Video. Okay.
So you can see here the 5. And you do parallel to the transverse fibers of the pons.
Paulo, o som do vídeo não sai, então você tem que ir falando, porque ele não, a gente não escuta o som do vídeo.
Ah, okay. So sorry, I thought you could also listen. So we did the incision in the so-called peritrigeminal zone. They are using a lot of these safe entry zones. Again, that is not really a safe entry zone. You do have to know where the lesion comes closer to the surface, and then try to utilize what you know to find your way or where you can cause less deficit. And again, here, it's very important not only to remove the hematoma, but you do have to look where is the live cavernoma, where you do have the malformation itself. And here you can see our development venous anatomy, the DVA, and you can see the small grape-like parts of the cavernoma. And this is what you really need to remove, not only the blood, the organized hematoma, but actually these small portions of the live cavernoma. Otherwise, surely you have a recrudescence of the case. And here is the patient. You can see here the removal of the petrous apex, which was the way that we gained exactly towards that very anterior portion of the pons below the 5th cranial nerve. Now, in this case, it's a little lower. It's almost at the transition with the medulla. So it's lower than the other one that we saw. The anterior petrosal approach will give us the space below the 5, but hardly you can see the 7, but it's very difficult to see the origin of the 7 on the lateral medullary recess. For that, in this case, we combine with the posterior petrosal approach, which your inferior limit is going to be the lower cranial nerves, but the center will be the 5 and the 7, and you have fully access to that region, the inferior portion of the lens, the pons, almost at the transition with the medulla. Also, the trajectory, your angle of view, will give you an inferior to superior direction, which is going to be easier for you to recognize the 5 and the 7 cranial nerve. So here is the lower portion we are seeing. Here is our 5. Here is the choroid plexus. Sorry, this is our lower cranial nerves. This is our choroid plexus. And here you can see, no, that's 7. This is the lower cranial nerves, and this is the choroid plexus. So here you can see, this is the biggest one on top is what it's the 9, the glossopharyngeal nerve. And here are 7 and 8. 5 is more superior. We are on the right side. Now, our incision, you're going to have to use the origin of the 7 as your guide. So we go medial and lateral to the 6. 6 was passing medially to that, and between the 5, the 7 and the 6, but again, laterally to avoid the descending fibers of the corticospinal tract. Once again, you find the hematoma, you remove the hematoma, and then you have to look for the live cavernoma on the wall of the cavity. In case you find the venous drainage, we don't coagulate the venous drainage because the venous drainage is also draining normal tissue. So that's not our goal. Our goal is to remove this grape-like appearance, which are the cavernoma itself. And here is our post-op. You can see here exactly at the transition of the pons with the medulla, okay? The total removal of the cavernoma. Now, here we have another case. This patient was seen before, just one bleeding, but you see that is very far away from the floor of the fourth ventricle. So this is very hardly a candidate to enter now to remove this lesion. Fourth ventricle, it's a very sensitive area. So we do prefer to enter for the fourth ventricle in case the lesion comes to the surface. So sometimes you risk to wait for a second bleeding. And here it is. So here we have the fourth ventricle, or the so-called rhomboid fossa, which the superior portion is the pons, while the inferior portion is the medulla. Fourth ventricle, usually when you open the fourth ventricle, you can recognize the medullary stria coming from the lateral recess towards the midline, crossing the midline, of course, and going to the other side. You can easily recognize the midline, and two structures that come a little bit more superficial, that are the medial eminence. Lateral to the medial eminence, there is a sulcus, that's the so-called limitant sulcus. Within the limitant sulcus, you have two depressions, one superior depression and one inferior depression. Superior depression is related with the motor nuclei of the trigeminal nerve. Inferior depression is related with what we call the trigone of the vagus. So in the inferior half, this arrangement is what we call the calamus scriptorius, because it resembles a pens. We can identify one medial triangle, that's the hypoglossal triangle, one more lateral triangle, that's the vagus triangle. Most of the times you can see a very small whitish band, and that's what we call the funiculus separans. And then again, a very dark portion where the gray matter comes to the surface, that is the area postrema. The area postrema surrounds the opening of the fourth ventricle with the medullar, the central canal of the medulla. So this is what we call the obex. Lateral to the obex, two protrusions, which are the cuneiform tubercle, the gracile tubercle, and lateral to it, what we call the cuneiform tubercle. So they are continuous with the gracile tract and the cuneiform tract. Superior to the cuneiform, you have this structure here that we call the restiform body. And the restiform body is formed by the junction of fibers that are coming from the lateral portion of the inferior lateral portion of the fourth ventricle, which are the vestibular area, and the connections of the inferior cerebellar peduncle. So here again is just a closer view. You can see stria medullaris, stria medullaris. We can see here the sulcolimitans, the inferior fovea, the hypoglossal triangle, the vagus triangle, here, the funiculus separiens, and the area postrema. This portion here is the vestibular portion, superior fovea related to the motor nucleus of the trigeminal nerve. And then just superior to it, we can see this very darkish area that is the locus ceruleus. And covering the superior aspect, we have the superior cerebellar peduncle. So now if we dissect this area to see better what is behind the ependymma, you can see that within the medial eminence, there is a protrusion, an elevation that we call facial collicular. Although if the name is facial collicular, it's actually related to the nucleus of the abducens, the sixth cranial nerve, while the facial nerve turns around to go towards the lateral recess and go towards the surface, passing through the transverse fibers and the descent fibers in the base of the pons. Here, the only nuclei that the nerve comes directly towards the fourth nerve is the cochlear. So this is the dorsal cochlear nucleus. While here you have the vestibular area with the vestibular, inferior vestibular nuclei, which is the biggest one, which has strong connections with the cerebellum via the inferior cerebellar peduncle. And here is our dissection of the hypoglossal and the vagus triangle. And this, we removed the area postrema on this side. We can see here on the other side. And we can see that this area postrema connected with the other side in what we call the interpostrema commissure. So, to enlarge this area, you should not cut this, because this is maybe related to the rhythm of the heart. And then here we have the posterior medial sulcus, the gracile tubercle, and the cuneiform tubercle that we know those will be the origin crossing anteriorly of the medial lemniscus that is actually the division in what we call the base and the tegmentum of the pons. Now, to explore this region, we go in what we call the uvulotonsillar approach between the uvula and the tonsil. So this was later popularized by Rotten as the telovelomedular approach, but it was first described by Yashargi as the uvulotonsillar approach. In shortly, what is the goal of this approach? Is to communicate the Mackenzie with the Luschka. And with that, you free up the tonsil and you can elevate the tonsil to have access to the lateral recess towards the midline too, and then you can shoot upwards all the way towards the aqueduct. And this is so the original description of Professor Yashargi. So here we are seeing, we can see here the stria medullaris. You can see the elevation that the facial colliculus are going just underneath the facial colliculus. Of course, you do have to use neuromonitoring for that, so you can add more safety. But again, you do have to know your anatomy and try to find your landmarks. The easiest one is the stria medullaris. That is the easiest one to be recognized. And from that, you can start to build up your points of reference. So once again, you have to go not only after the blood, but also of those small grape-like appearance which are actually the component of the cavernoma. And here is the patient with fully preservation of the sixth nerve, which was really what was directly involved in this approach, together with the facial nerve. Here again, the patient with total removal. Now, if we go down, we can see now a lesion located in the medulla, on the lateral aspect of the medulla, ventrolateral aspect of the medulla. So again, it's a lesion located more or less close to that recess. Here we have inferior circumforamen, which is the midline. It's the upper portion of the anterior medullary sulcus. Just lateral to it, on top of the pyramid, we will have the origin of the sixth cranial nerve. Then you have this recess, what we call the supraolivary recess. We have here, so the inferior olive, the pre-olivar, retro-olivar sulcus, and then again you have a space that is the lateral medullary recess. On top of this lateral medullary recess, most medial one, you have the facial nerve. Lateral one, you have the vestibulocochlear nerve. Within the dorsal-medullary, dorsolateral sulcus of the medulla, then you have the origin of the 9th and 10th cranial nerve. Again, your limit inferiorly of the medulla is the decussation fibers of the pyramid that can go on for more or less 10 to 15 millimeters. The posterior limit is the medial lemniscus. So everything behind the medial lemniscus is the tegmentum of the medulla and the tegmentum of the pons. So behind the medial lemniscus is where you will find the cranial nerve nuclei, and also the integration of all the cranial nerve system. In front of it, you have mostly descending fibers and transverse fibers of the medulla. And also here, we removed the pyramid. You can see here the olive. In the pre-olivary, you have the origin of the hypoglossal rootless. On the post-olivary, you have the recess, and then the dorsolateral sulcus of the medulla, you have the origin of the 9th and the 10th cranial nerve, while exactly at the border, the junction of the medulla and the pons, the pontomedullary sulcus, you have the 7th and the vestibulocochlear complex origin on the lateral aspect. Posterior also to the olive here, you have the ascending fibers of the spinocerebellar. There are two. This is the dorsal one. Also, you have the restiform body with the connections of the accessory cuneiform and the connections of the olivary nuclei with the cerebellum. All of these will form what we call the inferior cerebellar peduncle. Here you have the dentate and the superior cerebellar peduncle, the 5th cranial nerve, the most medial and anterior is the motor nucleus, but there is extension superiorly that we call the mesencephalic tract and nucleus, and also inferior, the spinal tract, spinal trigeminal tract, and nucleus. And then here you have vestibulocochlear. See that the cochlear go around dorsally of the inferior cerebellar peduncle towards the lateral recess of the 4th ventricle, while the vestibular come in front, ventral to the vestibular, to the inferior cerebellar peduncle. So this is another way for us to find it. And how to expose that area of the medulla ventrally. For that, you do have to remove bone that will keep in front of you if you try to do just a simple retro-sigmoid approach. You have to go more lateral and more anterior. Sometimes you do have also to mobilize the vertebral artery to gain this access. And then you drill what we call the occipital condyle. How much of it you drill? Well, it will depend. Sometimes you even have to check by opening the dura, seeing how is it anteriorly, if you have to drill or not more. But you're going to drill on top of the hypoglossal canal towards what we call the jugular tubercle. In this way, I don't think we're going to see the drilling of the condyle. This was not playing. I'm sorry. I hope Professor Almeft can show in his part of the presentation. But here is the intradural part. So here we can see the 7 and 8 complex. Here we can see medial to them. Where is the entry point? This is the medulla. This is the olive. So we are entering lateral to the olive in front of the facial. See that this is the pons. It's almost at the limit between the pons and the medulla in the very top of the lateral medullary recess. Here is a more organized hematoma, but once again, you have to remove the hematoma and seek for those bloods that are the live cavernoma without damage the venous drainage of the lesion, because as we know, it also drains normal tissue. And then here we can see the total removal of the lesion and the patient with the facial nerve function preserved. Another case to finalize is this case located at the quadrigeminal plate. So this patient had a small bleeding before, he was followed up and then it bled again. You can see that the lesion is much bigger. There was a concern if that could be or not only a cavernoma, but another different kind of vascular malformation. We did our angio, but we didn't see any alteration. Here you can see the classical Parinot syndrome, where the patient cannot look upwards and cannot converge. So here is the lesion itself. Here we have the quadrigeminal plate, which the limit superiorly is the pineal region. You have the posterior commissure. Here we have the apenula commissure, the pineal gland, the infrapineal recess. You can see superior colliculi, inferior colliculi. They are divided by the cruciform sulcus, which has a longitudinal and transverse segment. You do have connecting the superior colliculi with the lateral geniculate body, the brachium of the superior collicula, and connecting the inferior colliculi with the medial geniculate body, the brachium of the inferior collicula. Here you have, continuing here, the lateral mesencephalic sulcus, anterior to it, you have the lateral dorsal portion of the crus cerebri, and this is the lemniscal triangle. Inferior to the inferior colliculi, you have a recess just lateral to what we call the frenulum of the superior medullary velum. And this is where the cochlear nerve cross, and the apparent origin of that is just inferior to the recess of the frenulum. And here, covering the superior aspect, we have the superior cerebellar peduncle, which are connecting by the superior medullary velum, where you have the lingula of the cerebellum. Now, the quadrigeminal plate, especially the inferior collicula, it's a very important connection with the vestibular system, and it's very important for us to maintain or to organize the movement of the eyes as well as together with the head and with the body. We can see that this midline, it's a very important crossing, decussation, but also a commissural portion where you have the lateral lemniscus coming towards the inferior colliculi, and from that towards the inferior contralateral medial geniculate, but as well as through the inferior brachium towards the ipsilateral inferior colliculi. Superior colliculi, it's very important for also the conjunction of the head and the eye movement, and there is very strong connections with the pulvinar, but also obviously through the superior brachium with the lateral geniculate body. So although some people say that you can easily cut in the middle or inferior, it's not really like that, because especially this decussation can lead to a lot of depth, especially with the eye movement. Now, Professor Yashergil described it to go supracerebellar to gain access to that area. We did a little of variation of that in what we call flyover, because we go a little bit more lateral and also expose the angle of the superior and lateral surface of the cerebellum, going through that corner where you can have more space towards the quadrigeminal area. And here we can see in the video, you can see the tentorium. We are opening the arachnoid. On the lower portion, we're going to see the fourth nerve. It was just a glimpse of the fourth nerve, but then you know that above it, you have the inferior colliculi, and then you try to find where the lesion comes closer to the surface. Once again, you remove the organized hematoma and seek in the wall of the cavity for the live cavernoma. So this patient, in the middle of the night, he had a depression, and then we did the CT, and there was a bleeding that had to be evacuated. And when we analyze that, and this is the post-op, you can see that later it was totally removed. But when we analyze the pathology, show up that that was not a cavernoma, but instead of it, a true arteriovenous malformation. Professor O'Mafty always point our attention to that. In the quadrigeminal plate, be aware that sometimes it cannot be a simple cavernoma. If I'm not wrong, he has 2 or 3 cases of vascular malformation, of arteriovenous malformation, mimicking cavernomas, that happens to be all of them on that area. And this is the patient in the post-op. You can see that she fully recovered the Parinot syndrome that she had. And thank you very much for the opportunity. And then now, Professor, will continue. I will stop sharing.
We have time for more, or the time is up?
No, we have plenty of time.
Professor Borba, can we keep on talking?
Yeah, we can. We have lots of time.
Okay. Now, the vascular malformation or the cavernomas is the interest of everybody. But equally operable and curative are a tumor of the brainstem. Do you see my screen?
Yeah.
Yes, you can see.
Okay, let me see. And I just want to talk to you about the area of the medulla to emphasize something for you. The medulla scared me the most. Because just imagine if something happened at that level. You're talking about somebody, no movement, no sensory, no respiration, no swallowing, from the neck down. It's the most chilling condition you could imagine that the patient will end with. But I still believe that benign tumor of the brainstem, like this one, is very obvious that it is a cystic and dense vascular. It's a hemangioblastoma. That's frequently it's a multiple and part of von Hippel-Lindau disease. And the treatment is the surgical removal. The trick in here that in hemangioblastoma, really you cannot enter them. Otherwise, it's very difficult to stop the bleeding. And if you use any pressure, then you're pressuring the medulla, then you really got problems. So these need to go around them very carefully under high magnification. Do not take the venous draining out like any other AVM or very vascular tumor. Because if you take the venous out first, then the patient will have uncontrollable bleeding more. You could see how the vein is protected to the very, very end. And then at the very end, we could, after totally freeing the tumor, we could clip the vein and remove those tumor as one piece in total. So hemangioblastomas are benign tumor of the brainstem and can be curatively totally removed. This is the same. Obviously, if it was enhancement, you would see a very dense enhancement. And these are the pilocytic astrocytoma. They happen in the midbrain, they happen in the medulla, and they usually, the one in the pontine are the malignant infiltrating. But in the medulla, they are surgically and totally removable. Obviously, tumor like this will require, again, a transcondylar approach to come in from the side, staying behind the pyramid. You could see here we're opening the pia of the medulla. And that's the tumor is very typical that the yellowish, grayish, frequently suckable or almost suckable. That's a pilocytic astrocytoma. And you could progress with it, opening the medulla down in the upper cord, the pia. And follow that, obviously here needed a low, very low setting on the CUSA, different than meningioma. And then we almost got to the basilar artery up the front. But the normal medulla tissue, it's all compressed to the opposite side. So these also can be totally and curatively removed. And again, this is the chance of this patient to not just take the tumor, but improve their neurological deficit to present preoperatively. Now, these are the intraparenchymal tumor of the medulla. They could be as big as this one. This young girl came in almost comatose one night. A typical medulla giant pilocytic astrocytoma. It rendered itself to total removal. And neurological deficit that almost was comatose recovered. And here she is, will invite you 15 years later for her graduation. And there is no greater reward. These are all intraparenchymal. The problem with the medulla is the tumor that extraaxial. Because in the extraaxial, you could see the vascularity that is going into the medulla. One of those vascularity is those little perforators that come out from the junction of the vertebrobasilar. More medial to the anterior spinal artery. Not many people recognize them even from the time of Stafford, said arises from the medial aspect of the vertebral artery, breaks up into number of fine twigs, which enter the lower part of the bulb. It seems to have been invariably omitted in a previous description. And it seems invariably not talked about in neurological experience. He's Roten and the late Dr. Oliveira seminal paper. You could see they are in the illustration, those little tiny twigs coming out just from the junction of the two vertebrae. Distal up to the spinal artery. Here, Yazergil illustrations and pictures. You see them, those little tiny perforators coming up from the medulla. Where do they go? They go in that intramedullary sulcus. Right there, and you could see if you split the two pyramid apart, you could see the perforation where those small twigs of perforator goes in. Again, you know, it doesn't matter how many times you see the Mona Lisa, it always looks more beautiful than the last time. And that's my problem with Dr. Kadri, dissection and illustration. They're just so beautiful. You never stop looking at them over again. You saw some of them. You gotta get the Atlas. It's gonna be a classic of science and art. But look at that. He shows again here the intramedullary sulcus, and you show this one, taking it back to the pyramidal decussation. And this is his dissection too. See down there at the junction of the basilar vertebral, becoming twigs of perforator going right into that intramedullary sulcus. So what do they feed? Then let me show them to you surgically then. Here, after the removal of meningioma, and as we take the tumor out and look at the vertebral basilar junction and look at the small, tiny perforator coming down from the junction, more distal to the spinal artery. To have a patient intact, this has to be preserved. And here's the lesson. Same thing, meningioma. We're operating. Look at it now. We're coming back on the vertebral up, higher up. And look in here somewhere, it comes in. You start to see the perforator. You see them off the vertebral right there where I'm putting the side. Here another one. Okay. And we're operating where the monitor said, I lost the motor response. See, what the sensory response? Oh, fine, and nothing has happened to it whatsoever. What do you mean you lost the motor response? I did. It went flat. The sensory, oh, the sensory is fine. And you could see here, the motor is flat. You could see here, the sensory unchanged whatsoever. And woke up the patient, cannot move 4 extremities, but perfect sensory function. The post-op MRI, there is no full infarct. The diffusion is negative, but there is right in the pyramid, both sides, just in the pyramids, that hyperintensity or edema or ischemia or something that made her paraplegic, but intact sensory, give her what we call Duchenne syndrome. Both pyramids, sometimes it expands to the hypoglossal nucleus. Correct me if I'm wrong, Cadres, but it's very specific on bilateral pyramid coming in from those perforator I showed you that goes into the medullary sulcus. Luckily, few months later, she fully recovered. And if the other graduation picture is the greatest award, when I saw her, I did my greatest prayer. I'm just so grateful to this. So please, around the medulla, especially outside, like the top of the basilar, there is vital perforators. In the bottom of the basilar, there is even more vital perforators. I thank you all for listening to us and putting us with us. I thank Dr. Kadri for a beautiful presentation. And man, those picture is so beautiful.
Professor, but he needs to finish the book.
He did. It's coming out. I'm gonna buy 100 and give them to the 100 generation to come.
Okay, thank you, Professor. Thank you, Paulo, for the Wonderful presentation. I open for the panel. Have question to Dr. Paulo Cadro, Professor Yashagil, Professor Omefti. It's so beautiful as Yashagil that it reminds me of Professor Yashagil. Please go ahead.
Good night. Good night
Eh.
for everybody.
The guy from the army. Go ahead.
Yeah. I have one question for Professor Omefti regarding the time to operate a brainstem cavernous malformation. If you wait sometimes after the bleeding, like 1 week or 2 weeks, or if you do not take into account the time after bleeding, because sometimes when we do a surgery later on, the cavernomas is more hard, more adherence to the structures. And when we do the surgery in 1 to 2 weeks, it's more soft and the blood is more easy to take it out. Do you have some point about it?
To me, I really, if you do it very early, okay, if you don't operate, as the hematoma is gonna be organized and some absorb, the patient's gonna get better, okay, on their own. Every deficit after bleeding, it will not totally disappear, and the additional of hemorrhage will even add more deficit and more deficit. But the deficit from the acute bleed, they usually get better because the hematoma absorbs some and organize. Okay. Now, if you operate early, you take the credit for this improvement. Which, but might be even more improvement than if you left it alone. And I think so. Now, but that's not your question. Your question is, doesn't matter if it was in the first 5 days or 2 weeks where the tumor, where the hematoma become more solidified. My thought, and Paulo thought and said it very clearly, the hematoma doesn't matter really. That's not what you're treating the patient for. I see them, some videos going in and pulling it all in one piece and that's over. Well, that's only blood the clot. Many times it could be different ages of a blood the clot. Even sometimes could be so old that the classified part, calcification part of it doesn't matter. That's a hematoma. What really matters to avoid rebleeding, it's the live cavernomas that's still in the wall of the big clot you took. So after taking the clot, one has to get to the live and be sure you get to the clean gliotic surface between the removal of it or not. Would that be made any different if it was done where the blood is still fresh, or 2 weeks later when it became more organized? I don't know. But the emphasis here that if you really want to treat the cavernomas, you want the treatment purpose not to bleed again, you know, like the aneurysm or the AVM. And what the bleed is not the hematoma. What the bleed is a still remnant of live vascular malformation or vascular cavernous things. And that's what need to be removed. That's what you saw some of those videos. You're coming down to a nice gliotic surface of the brainstem. And if you search for them in the bed of the hematoma, you will find them. You will find live. We saw them. And that's why many people put the cavernomas as a blackberry. You know, the real dark, live vascular channel. So I don't know if 1 week after surgery or 3 weeks after surgery make any difference whatsoever. I just never thought of it that way. What do you think, Paulo?
I agree with you, Professor. I think that sometimes maybe before the cavernoma is completely organized, it's easier to drain the hematoma and then look around and see the wall. Yeah, it's gonna be easier if it's not that solidified, not that organized. I think
Jan wrote the paper.
No,
What do you think, Jan?
it's classical, Professor. It is classical. Everybody say, if you wait 2 weeks, 1 or 2 weeks, the field will be more organized. And the possibility to have damage to the brainstem is much less. If you go in acute, the brainstem is swelling. It's more difficult. Maybe you have more deficit.
Jan,
You have
what
the
do you
bleeding, you
think?
go in acute.
Yeah,
See?
thank
The
you,
brainstem will
Professor.
be swelled. Maybe you have to wait.
Thank you for including me in this discussion. Like Paulo showed us beautifully, the brainstem, it's a very complex anatomic part of the encephalus. So a small bleeding in the supratentorial part, sometimes the patient has no symptoms. But if you have the same amount of bleeding in the brainstem, the patient can be completely devastated. So I believe that if you remove the clot, the hematoma in the very early stage, maybe you can achieve the first goal of the surgery, which is decompress the brainstem. And sometimes I have a couple of cases, 2 cases that await some weeks or months to operate the case, and the later MRI showed a brainstem cavernous malformation in the middle of the brainstem. But if I had operated the patient in a very early stage, I have the way through the hematoma to achieve to go up to the cavernous malformation. But after wait the reabsorption of the hematoma, I have to go through the brainstem fibers. So for that case, I would say that would be better to operate in a very acute phase of the bleeding. First, because the compression could be good for the patient. Second, because the bleeding can make the way up to the middle part of the brainstem cavernous malformation. So I'm changing my mind, and I really believe that we have some advantage to operate in the acute phase of the bleeding.
I think this is not the question that Jorge did.
Now, George said, if you have to wait or you have not to wait.
No. He's not asking
hematoma.
to wait the hematoma completely absorb. And he asking that not go in the first day or second day. Wait 1 or 2 weeks that you more organize the clot. The surgery will be much easier. Then you go in acute phase. Bleed in the morning, you operate in the afternoon. I think here's the question, eh, Jorginho?
Yes, this is the question. If you
Yes.
wait 1 to 2 weeks, it's more easy. The clot is more organized.
Yeah,
You drain the clot more easy, then you can see better the brainstem tissue and the gliotic and the live cavernoma when you in a hyperacute phase.
Yeah, this is the question. Yeah.
And might have the gliotic plane separating the brainstem from the hematoma to better.
Yes, yes, it's the idea. It is the idea. Yeah. When you go in acute, you suck the brainstem together. And let's make a question to Professor Paulo Cadre. And Professor Almefte will reply. Is there a safe zone in the fourth ventricle, in the floor of the fourth ventricle? Where is the safe zone? Why? Because when you show the anatomy, man, you make a small hole like that. When you finish the surgery, the hole is like that. It's true with everybody. Where is the safe zone in the fourth ventricle, in the floor? And the other question, why? Other question, why you didn't show the video that you did 2 weeks ago? A beautiful surgery. He did a very nice case 2 weeks ago. The patient is very well, very nice video. Why didn't show your video?
So coming to the first question. Coming to the first question. You know, Professor Bricco was the first one to propose this safe entry zones, right? And then afterwards, there were some anatomical papers actually trying to explain why those safe entry zones were safe. Well, as you all saw and as you all know, it's so crowded place. There are some places where theoretically you could accept some of the deficits, okay? So like the lateral recess, we could say that's a safe, because those are mostly vestibular areas, and those vestibular areas, they are bilateral, right? They are bilateral. So lateral recess would be a safe. Now, superior and inferior facial areas. I would say that's very hard. And as you saw, in most of the case, you're going to look for where the lesion come to the surface. I doubt that anyone really go through the fourth ventricle if the lesion does not show up on the surface, right? Midline, probably you have less fibers crossing at the midline, at the tegmentum, but then you can damage the medial longitudinal fascicle and have devastating eye movement syndromes. So I myself, to be short, I don't believe in safe entry zones in the fourth ventricle. I don't think so.
The safest zone is the shortest one, no? Independent of the place, or not?
You know, because sometimes the lesion almost goes towards the surface in the fourth ventricle. But if you have to pass through 2-3 millimeters in the fourth ventricle, sometimes it's better if you're coming from the side and you choose to go through the transverse fibers of the pons. Of course, if the lesion does not come all the way towards the surface, right? So even if the shortest way is the fourth ventricle, the floor of the fourth ventricle, sometimes it's better if you come from the side.
Dr. Mefti show one case in the pilocytic astrocytoma in the brainstem. And the classical paper, I think many years ago, the guy from Toronto, I think so. No, from from New York, Fred Epstein. They show that the two extremes, mesencephalon up and down, ponto medullare, or the safest one. And one thing that is very important is the clinical symptoms. See, if the symptoms have very short, very acute symptoms, especially cranial nerves, is more related with aggressive tumor. When the history is long and the patient has few symptoms in the large tumor, is more related with benign astrocytic polycythoma. The problem today, they are sending everyone to radiation therapy without know what is the real behavior. I just saw the presentation of Professor Boop, Frederick Boop. He has a large series, he differentiates the kind of tumor in the brainstem. It's very, very interesting. The other thing about the angioblastoma of the brain is inside the brainstem or is attached to the brainstem? Professor, because your case looks like it was attaching to the brain, it's not really inside the brainstem.
No, you saw the video. It's in the floor of the fourth ventricle to the side, not right in the middle. But
Or more the peduncle.
Hemangioblastoma are intraparenchymal tumors. Now, they could be in the cerebellar hemangioblastoma, fungating out in the CPA angle. But if they are small, they're parenchymal tumor.
Yeah, it was good. I think Jean has one very nice case that he did. Was in the posterior fossa?
The same thing in the spinal cord. They are intra-axial tumors. They could be in the CPA angle for fungating when they got very big.
Yeah. I don't know if somebody want to say something or make some questions. Have here Juan Luis Gomez Amador, Professor Marcio Hassi, Byron Salazar. Everybody is afraid to ask Dr. Omefti.
I see Dr. Arantovic up there.
Yeah,
Oh, he's awake.
I have a
Where
question
was
if I
he?
can ask.
I'm here.
Hemangioblastoma is inside or outside the brainstem?
Yes, both. It's inside, but it is distinguished as, you know, it's inside the brainstem, but it's distinguished. It has a little zone, PL zone, where you can't, as Dr. Omefti said, you cannot go inside the nodule, but you also cannot go inside the brainstem. So there is distinct zone which you need to go around and keep the rain preserved till the very end. But I want to say two things. First of all, I enjoyed fantastic presentation of both panelists. And just for Paulo, don't be like Luis Borba. Be like Dr. Omefti. When Dr. Omefti publishes book, he gives us a copy with his signature. When Borba publishes, no copy, no signature, no nothing. I want
It's
to
very
emphasize.
expensive, that book.
Laughing, he agrees, yeah. The second thing is thank you very much for showing us the beauty of anatomy and the beauty of microsurgery. I just got back from Europe and I had several more places I went, and it's like a war on microsurgery. Everybody talking about exoscope, endoscope, gamma knife. Nobody talking about microsurgery. I don't know what's wrong with our world today. It's like a war against microsurgery, against the proven entity that cures the patient and gives best outcome. So it's crazy, but as a phenomenon, it's like having a COVID and refusing vaccine and taking garlic and aspirin or something. But that's a different point. So I thank you for the webinar. I'm a student. I learned a lot. And thank you, Dr. Borba, for putting this together.
On that
No, no.
comment, Kenan, you need to invite everybody to join the Micro Neurosurgery Academy that it was established last year in June. And we will have the next Congress next June. And it's totally dedicated to advancing and teaching. That's the most important thing. So you're not going to have microneurosurgeon unless if there is somebody teach the microneurosurgery. Microneurosurgery Academy. Join, please.
Byron.
Good morning, good night, Professor Almefti. It's an honor to have you with us. It's always nice to hear from you. You're a beacon of truth and a true neurosurgical master, and I have the pleasure to follow and learn every time I see you. I have a question. We know that the reoperations rate in cavernomas can go as high as 6%, and sometimes maybe after 2.5 years after the primary resection, we can have another rebleeding. So in those cases, when you can do a post-op MRI and you see and identify an obvious remnant, what do you do with these patients? Do you take them once again to the OR and try to complete the resection, or maybe you just follow them up and see what's going to happen?
I think future recurrences, it's really one of two things. You know, if you have one cavernoma, you could have two cavernomas, and you could tell that familial syndrome from genetic study right now. You could identify them right away. But a lot of them, like you said, is from residual cavernoma that was not removed. And unfortunately, that was a very common practice. You know, people happy got in, so that big yellowish, ugliest things, many times they could pull it out all in one piece almost. And the real life cavernoma is left on the wall, and it's gonna bleed again. Now, but your question is, if you got an MRI and you found that you left cavernoma, what do you do? Probably wait till it bleed again. And just hope it will not bleed again.
Thank you, sir.
I think Dr. Rui, you want to show a case to Dr. Almefti?
Hi, how are you? Good night. First of all, thank you all thank you, Professor Barber, for inviting me here. Yes, I thank you, Kadri, and thank you, Almefti, for these great presentations. As everyone said, you're always a beacon that we should all follow. And the microneurosurgery is this: it's knowing anatomy to the finest detail, and that's what makes surgery possible. The more you know, the more you see. Actually, I have a case that I would like to show, because we've been talking about cavernomas. And
please share it. Please share the screen.
Yeah, I will. Just a second, please. Okay. And can you see the screen?
Yes, yes.
Okay, so this is a case of a 32-year-old male.
No. Now I'll show you a different thing. Cuffing. What is that? Is it cuffing?
No. Yeah. Ignore this, please. I'm just connecting.
Okay, go ahead.
Yeah. Oh. So this is a 32-year-old male. He has a history of left side hemiparesis with hyperreflexia and nothing else. This is just a slight hemiparesis, grade 4+. And this is the images that we have. So this is the flare.
Oh,
This is a lesion that is anterior in the medulla and extends all the way up to the pons. And we can see that it's centered to the left pyramid. And we can see here, for instance, the olive, the inferior olivar nuclei. And it seems that it grows, it has an exophytic growth here to the left side. And so this is the contrast. And the question here, because when we talk about the cavernoma, so there is no contrast here, no contrast enhancement. In T1, it's hypointense. And we see it's centered. I will try to make this bigger, sorry. And we see that it's centered to the pyramid, to the left. Can you see the lesion? Can you all see?
yes, yes.
Yeah.
How
so
old
it's
is the patient? 32.
32.
What are the symptoms?
Just left side hemiparesis, but he is fine. It's just a slight hemiparesis.
How long
And
the
it-
history?
It's like 6 months. It's a short history, and it's progressing. And we can see that somehow we can see the here the medulla pushed backward. So this is
No cranial nerves.
No cranial nerves. Just no cranial nerves, no lower nerves, no dysphagia, no dysphonia, no nothing. Just the motor deficit. And I can.
You have the
T2
sagittal cut?
Yeah. So, sorry, just let me take this out of the way. The question, because here in the I saw, I don't know if you know the Sure's presentation.
Oh.
He showed these cases of 200 plus patients he operated, but he showed 400 cases. So it's like 200 he operated, 200 he did not operate. And I think this is the most difficult thing now, is to see how far can you push the indication. Let me try to see if this is better. So this is the flare. So my question here, in this case, is
There is no enhancement,
no, sorry,
no contrast enhancement.
no contrast enhancement. So you can, if you want to see sagittal contrast, is this one. This is with contrast. So what to do?
Did you do tractography?
No, and the diffusion here is not enough not enough directions to do the tractography. But it's important, of course, yes. But it's really centered to the right to the left pyramid, right pyramid. Sorry.
Yeah, this is pilocytic astrocytoma, probably. But it can be also on the malignant side, depending, because he's getting to that age where it can be on more aggressive, like grade 3. Tough decision, he's pretty much intact, as you said. 4 plus
Yes.
5 is intact. Tractography you cannot do, it's diffuse, it's going up and down.
Exactly.
It is getting to the surface at a couple of points, and that may be your entry point. And
It's not.
and Paulo, better to ask them.
It's not polycytic. I don't think it's polycytic. It's too diffuse.
It looks
But
diffuse.
6 is round, you can see very well and define
But
very
that-
well.
Louis, doesn't
This is
enhance.
diffuse.
And it goes into the
It's more aggressive.
basis ponti, so it's going through the trajectory. So you see here in the tegmentum, but also in the basis ponti. So it's like following the motor fibers on one hand, and the other hand it's following also in the tegmentum. So but it's more motor here when we go to the pons, and then when we go down, it's centered, but it's also going back. So it's two different compartments here, I think. And the question is, what should we do? Should we just try to do a biopsy? I think to wait and see, it's not an option in this case. We should have a diagnosis. I don't know. What do you think?
I'm silent because I don't know what to think. No, if you look at the sagittal, it looks like Borba said, a more diffuse lesion than the demarcated lesion of pilocytic astrocytoma. And it looks like it is in the pons. So, and correct me, Paulo, if I'm wrong. If you're looking at that, now some pilocytic astrocytoma of the medulla, it kind of pushed the pons up, displace it upward, but it does not break the barrier to the pons. This one seemed like went above the sulcus and it's infiltrating in the pons. So, do you agree, Paulo?
Yes,
No?
sir. No, yes, sir. We used to say if the tumor is confined in the
Yeah,
mesencephalum or in the medulla, they
yeah.
tend to be benign.
This
The ones
is
that
not.
are in the pons or crossing the boundaries, they used to be malignant.
Yeah. Now, the other
But
things, it really does not have the enhancement of a pilocytic astrocytoma. So I don't think this is the one which is totally surgically removable to cure this patient. However, you really want to know what it is, and it is already fungating. And now they're making a big deal about the genetic study classification, which will give you a good idea of the prognosis if it did not give you better targeted treatment. So yes, I will go and get pieces of it from where it's fungating out.
Right here.
And yeah, and you know the pathology for sure. And if it's pilocytic astrocytoma, here we go. But I'm very concerned that it looked a lot more diffuse than it could be surgically removed. And surgery is gonna be a limited value to the biopsy. And one might say, oh, this is a diffuse infiltrating a glioma, will come up grade 3 or grade 4. It doesn't matter. The treatment has to be these days. What they're doing, Borba, you're going from one radiation and chemo or what?
No, you had last week two similar cases here.
And is this a
One-
very young or old?
It's a 32.
If
This
it's
guy
a young
32.
patient,
I'm-
you're thinking of cystoplantin and all of that stuff.
Yeah. Let me say something. We are seeing more and more often brainstem tumors in adults with this pattern, you know. We had one, I think 3 weeks ago was 30 years old, and now 1 week ago, 55 years old. that it's not common to have brainstem malignant or glioma in the brainstem in adults. I don't know why it's changing this. I don't know. Something that is changing.
And you see the
Very
T1.
similar pattern. Very similar pattern. They show you, Paulo, there is one that we saw. The lady, there is another lady that they showed me, last week, with 55 years old, with the same thing. I don't know.
But this is also strange because it's not just, even if we think about the motor parts of because this is embryologically, this are two different parts, the motor and the tegmentum.
And we see the T1. Because
T1.
flare in T2, sometimes you see the edema.
Yes. I can show the contrast enhancement T1 if you want, because it's the same, because it's not contrast. I can put it bigger. So this is the bonds.
Yeah, it's not well defined. Yeah.
No, and but here there's this exophytic part, and it's almost like if the medulla is pushed back here. It's kind of strange, but so this part is all exophytic, and then so it's very strange. Here you can see this is the pyramid before the decussation, probably, and it goes all the way down. Probably here it crosses, I don't know, and then up again.
Yeah, but at least the exophytic part you can remove, right?
Well, I don't know if
I think the surgery here is not for removal. The surgery for diagnose.
How is it on the fuse?
Yeah, it's diffuse. You see, in the sagittal cut, you see they go up and down.
DWI.
Yeah.
Okay. DWI.
Okay. Thank you, my friend. Let's see. If you want to do something, please tell us what you did and what is the pathology. Okay.
Okay.
Almost 2 hours here. Always, Dr. Amef, you have more and more and more. You call in Brazil a resenha. Como é que você chama a resenha? How you say the resenha, Paulo Cadre?
I have more dinner and good night.
No. Like after the game. After the game, we stay discussing.
Yeah. After
now we have
movie.
a new Mona Lisa. Ay. Okay.
If you have a time, if you have a time,
Juan Luis, if new face, look at that. Where is the bird?
It just good night, everyone. I just want to say it's always a pleasure to see Professor Almefti, so we can refresh our souls and to remind us the importance of microneurosurgery. And Paulo Cadre has given us the perfect example of how do we need to approach a patient. So we have the diagnostics, we have the clinical status of a patient, but most importantly, we prepare the surgery. So the anatomy is the fundamental part to perform this kind of procedures. So he showed us in a very didactic manner how can we approach a lesion if we know the anatomy in the proper conditions. The three-dimensional concept of the anatomy, as Professor Almefti showed us, but also it's important to have the proper tools. I noticed that the Professor Almefti and Cadre are using those Yashargil bipolar forceps that you can spread and dissect the lesion with a very precise manner. So it is important also to let know the people that the instrumentation is also a very important part of a procedure. And as a Professor Almefti have always said, you need to remove the bone and leave the brain alone. So in these examples, we see very the application of these skull-based techniques, so we can reach an intrinsic lesion. So skull-based surgery is not just for extrinsic lesions, right? Not for meningiomas, pituitary adenomas, etc., but also for intrinsic lesions. In that way, we can preserve the anatomy and we can go directly to the lesion, as we saw in these beautiful videos. I want to thank you, Professor Mefti, Kadri, and also to you, Professor Borba, for this great opportunity. And the most important part for me that I take to myself is to prepare the case every time, very precise, and to be the better for the patient. And the microneurosurgery is the fundamental part, together with anatomy and the proper instruments to achieve this result. Thank you very much.
Juan, don't go away. I'm gonna now ask you the tougher question. If a cavernoma ventral, totally ventral, you choose it, medulla or pons, okay? Totally ventral, right in the middle. And coming to the surface right in the ventrally. And very far away from the fourth ventricle and from the lateral approach. Will you do it entirely with endoscopic technique?
Yes, Professor. I
He
think
did and published.
Yeah, for some very case.
Show it to us.
Yes.
He did and published, Professor Dr. Mefti.
Yeah, show it to us or give us the reference.
Should to study more.
No,
how did it go?
These cases account for a small portion of the lesions, and the transcribal endoscopic approach gives us a complete, wide view of the surgical field that we need to decompress the brainstem and also to take out the active portion of the cavernoma. I think that what we need to learn is that these cases are very specific, as you are saying. Most of the times, the lesion comes around the brainstem, so you can take it from the lateral part, right? But for those very specific ventral lesions that protrude through the transverse pontine fibers, as Polo mentioned, I think this could be a very good option of surgical approach. Yeah.
Yeah, very nice.
If they are in the midbrain, that means in between the two pyramids, right?
Yes, sir.
Higher.
And if they are in the medulla, that also means between the two pyramids.
I think for mesencephalic lesions, endoscopic endonasal approach is more difficult because you need to transverse the pituitary gland in order to reach up. So I think the cranio-orbitozygomatic approach will be better for these lesions, although there are some reports by Gardner in which he take out cavernous malformation from the mesencephalon. And for the medulla, I think the low transcribal approach could offer us this nice view, as you said before, the junction of the two anterior spinal artery from the vertebrals. You are able to look perfectly to those perforating vessels from in front of the patient.
But the case that we published was on the surface. Was very nice. You can see the video was coming subepio. You could see before opening the brainstem was possible to see the cavernoma. It was a wonderful video. Is in the operative neurosurgery.
Yes.
Can you find it?
I don't have my computer with me now, but I will send it to you.
Send the link.
Yes, sir.
Okay. Thank you. Jean wants to show something, but the surgery start to bleed. He stopped the screen.
I didn't edit the video. So just to illustrate.
He's bleeding too much.
Yes, of course. Yeah, just to illustrate what we just discussed in this in this beautiful webinar. Let me.
Oh,
The
oh, this is the case to discuss.
yes,
This is
is
the case.
30 years old male presenting with a cavernoma which bleeds in the brainstem. As you can see here, the patient came to our ER almost comatosis and with tetraparesis. He was operated. That is a good example. When you decompress the brainstem, the patient recover well, like Professor Almefti said. Every time you decompress, the suction the hematoma, you have the credits for the improvement. And then that was the MRI, and the postoperative CT in the surgery showed that probably had some residual aspect of the cavernoma.
No, it's very nice.
Okay. Okay.
Which
so
approach you use?
The first surgery was a heterosigmoid approach. Okay.
It's perfect.
Yes, but
Why did
looks
it come
like
through the floor of the third ventricle? The fourth
the
ventricle.
fourth ventricle to avoid the floor of the fourth ventricle, like we discussed
Okay.
previously.
Okay.
Paul said beautifully that every time you can go more lateral, you avoid the floor of the fourth ventricle. So, but the patient improved a lot. So he was discharged to rehabilitation, and he improved a lot. He became to us almost dead, and he came after surgery very good recover. And so less than 1 month after the surgery, he got back in the ER with this CT scan. He felt a strong headache with this CT scan, which showed a new bleeding in the brainstem. Okay, so that was our hypothesis, that probably has some small residual. And less than 1 month, the patient present another bleeding in the brainstem. And then we did the MRI, which confirms that had some residual. So this case illustrates again, when you operated in the very early stage, you have a very good way to reach the lesion. But now after you remove the hematoma from the bed of the cavernous malformation, now you have a lesion more in the central part. So you have to open the fibers of the brainstem to reach the lesion. Because the patient has the second bleeding, we decided to operate again. Now we changed the approach. Now we decided to go supracerebellar infratentorial approach, because this residual was there. So this is the last preoperative MRI. And then we perform, okay.
It's very early.
Very
In
early
the first,
bleeding.
the first surgery. How many days or hours from the bleeding to surgery?
Less than 3 days. I don't know exactly, but it was less than three days because it was in the ER situation. So it was very early. And then this was the last CT scan after the final surgery. That was our approach, supracerebellar infratentorial approach, CT scan. And this is the last MRI showing probably the complete removal of the cavernous malformation. I didn't edit the video, so
No.
I can.
But this addressed very well what you are discussing early.
So you see, the lesion
if you could do again, you do the same thing, or you wait 2 weeks to have this, to approach the first lesion.
Look at how the lesion is attached in the brainstem. It's very, very attached. So if you wait sometimes you have this kind of situation. But what
No,
Paulo
no,
said,
no,
what Paulo said is
no.
very important. Look at the end of the surgery right here. This is the vein. You see? I was
No, you
endowed
cannot
in,
see. Cannot see the
Oh.
video.
oh, unfortunately. Oh, maybe stop sharing and share again. Screen. Now the video, okay? See, in the final of the surgery, I was in doubt if it was a little piece of cavernous malformation, but in fact, it was the main drainage vein. You see right here in the bed, right here. So we have to avoid to cause lesion this kind of vein. The images in the lateral, this is the tent and this is cerebellum. Let me show the end, maybe here. Oh, this is the lateral mesencephalic vein right here. And that under this was the bed of the surgery. So that was a image guided surgery. So the neuronavigation is very important in surgeries like this because it is very helpful to identify the entry point where the lesion is. So this case illustrates what we discussed, that maybe it's easier to decompress in the early stage, and after you remove the hematoma, you have only the lesion, but sometimes you have to open the brainstem to reach the lesion. If you don't remove everything, the patient will bleed again. And this case was very early, the rebleeding, less than 1 month. And like Professor Almefti said, you have to try to remove everything. Otherwise, the patient has risk to have other bleeds in the future.
Antonio.
Thank you, Bob. Congratulations, Paulo, outstanding lecture. Congratulations, Professor Mefti, for all the wisdom. I just want to give brief 2 comments. I think is as important as the point of entry in the brainstem is as Paulo said and showed us, is the direction of the dissection, the microsurgical, very good technique in the direction. So you have to learn with Paulo Cardwell all the fibers, and then it's the same technique that you do in the spinal cord tumors. Can you imagine if you do the dissection in the wrong direction in the spinal cord tumors? It must be a disaster. It's the same in the brainstem. So congratulations for both. And the other comment is, as Barbara said, we have seen many diffuse tumors in adults. I think this one that was showed is one of them. And they do better than the children. They have a better prognosis. They respond better with the radiotherapy. The only, I think, in those diffuse cases, the only role that we can have is taking biopsies. And there is a trial, because there is a specific mutation in those patients. It's H3K27 mutation, is a stone mutation. And there is a trial in Germany that they are using a vaccine for those patients. Maybe if you know and you can act in the right targets, it can be better in the future for those devastating cases. So congratulations and thank you for the nice lecture, sir.
Excellent. Jorginho, please.
Yes, I will share my screen to.
Everybody has a cavernoma.
Everybody has, but we are trying to talking about the things that we show. Let me see here. Here's the case, because I have some. It's not almost the same. It's a little bit different. We are saying the COVID time, it was misdiagnosed with COVID because of taste alteration, vertigo, but it was a brainstem, cavernous malformation. I will spend some part of that what we discussed previously, but we did a different approach, an extended retrosigmoid approach that is lateral position and expose all the sigmoid sinus, but it's like a lazy petrosal, posterior petrosal, not too much. And then we can have this kind of, and I wait 10 days to do the surgery. The patient was operated on 10 days. So opening the petrosal fissure and the brainstem, look the nerves, the 17, and we can, and this is the opening the brainstem, but this is what I want to show. It's more easy to dissect. It's a more fluid hematoma, not so hard, not so adherent. And at the end of the surgery, it's more easy for us to find the live cavernoma, to more adherent, for us to dissect. And you see the final of the surgery, like here, cleaning, no more lesion, and the patient very good. And this is the postoperative MRI, and this is what we are discussing. The patient was operated on about 10 to 11 days after the bleeding, not in the immediate time after bleeding. We purposely wait for this surgery, and this is actually the postoperative. As we can see here, we mobilize the sigmoid sinus, and it's more easy for us to have a view like this way. This is a different way, not a petrosal approach, but you can do the same as a different point.
Excellent, excellent. Good. Can you stop sharing?
Yes, I am trying to do it. Sometimes it's in a, yes.
2 hours and a half. Okay. Professor, you decide.
Good night.
Okay, next week you come back. Next week you
thank
talk
you so
about
much.
the surgery of the venous system. We have a lecture, Dr. Sabini from Italy, and Professor Colli talk about tentorial meningiomas, and Professor Apio Carvalho talk about Antunes, talking about parasagittal meningioma. Let's see. Reconstruct the sinus next week. Thank you very much, sir. Thank you.
Thank you,
Okay, bye-bye.
everybody.
Thank you.
Thank you, all the audience.
Thank you.
Thank you.
Okay, have a
Thank
good
you.
night.
See you next
Thank
week.
you. Thank you, John.
Week.
Thank you.